Okay, good morning, everybody. Can you hear me? You seem a very long way away, and I'm very short. So, hi. I'm one of the NETS consultants, and I've got lots of my team up at the top. I'm going to give you a bit of a flavour of probably some of the sickest babies that we move. So, a very big transition from Code Crimson now to quite a different setting in a different gear. So we're going to talk about fetal circulation and what's supposed to happen postnatally to enable a baby to transition to postnatal life, PPHN, and then I'll present a case just to reinforce the discussion points, and we'll allow some time for discussion at the end. And I apologize because I'm not sure where all of your sort of memory or understanding is of fetal transition. So if this is all old news, just bear with me. So just a reminder, so fetuses receive oxygenated blood via the umbilical vein, which is in sort of a dark magenta there. So that's highly oxygenated, but it's a low pressure system. Travels via the ductus venosus into the IVC, into the right atrium, and then most of it is shunted across the patent foramen ovale and then into the left ventricle and pumped out to the aorta, and some of it goes into the right ventricle, but not terribly much because the pulmonary vascular resistance is very high because the lungs aren't inflated, and there's no point in going to the lungs because there's no oxygenation. So there's a big shunt across the foramen ovale, and then the blood that does go out via the main pulmonary artery, most of it shunts across the ductus from right to left. So from the main pulmonary artery across to the aorta, taking that richly oxygenated blood to the aorta. In this system, the systemic vascular resistance is very low. So the aorta, the fetus's heart is pumping blood out to the aorta and to the arteries, but it's quite a low pressure system. And then it returns to the placenta because it's largely deoxygenated by the umbilical arteries, which come off of the internal iliac arteries. So if you see them, they're in pink at the bottom. So what happens at birth is a baby takes a breath, inflates their lungs, which inherently drops the pressure in the lungs because they're not collapsed and full of fluid. So you've got it opening up, that the pulmonary vasculature then starts relaxing and opening up, so the pressure falls in their pulmonary vascular bed, and you start getting alveolar recruitment and ventilation, which is really important, and then oxygenation as well. The fluid is cleared via various processes, and the systemic vascular resistance increases because the placenta is now no longer attached. So the cord is clamped. The pressure in the systemic system increases, and because you've taken a big breath and recruiting and the pulmonary vascular resistance drops, you get a switch in the pressure, and so the shunts across the patent foramen ovale and across the duct reverse. Okay, so you're no longer getting a right-left shunt because postnatally a right to left shunt would result in deoxygenated blood coming from the body into the right side and then straight across to the left side, but it's deoxygenated because it's no longer coming from a placenta. Yep? Okay. So what happens when this doesn't happen properly is that the pulmonary vascular resistance remains high and the systemic vascular resistance is either normal or low. And the problem with that is that the shunts then don't reverse as they should be. They don't reverse to a left to right shunt. They continue in a right to left pattern. So you're getting shunting across the atrial septum at the patent foramen ovale. You're getting shunting across the ductus, which is all taking deoxygenated blood back into the systemic system. There's also intrapulmonary shunting because if the lungs, the pathophysiology behind this process is if you haven't had adequate ventilation and you're not clearing carbon dioxide, you're not getting well aerated and therefore oxygenated alveolar, then your pulmonary veins, arteries, vasculature, doesn't relax because you get basically a VQ mismatch and you get that shunting. And that results in PPHN, which is persistent pulmonary hypertension. And the biggest factors that cause it are lack of ventilation, so lack of alveolar recruitment, lack of removal of the carbon dioxide. And so the baby develops a respiratory acidosis, and the acidosis then causes further pulmonary vasculature constriction. And the babies basically get into a vortex, and they very quickly just vortex down, and it gets very difficult to rescue them from that situation. So when you're resuscitating an infant, whether it's a preterm infant or a term infant, the primary goal is to adequately recruit and ventilate that baby to enable appropriate transition to postnatal life. So when that doesn't happen, the baby then develops hypoxic respiratory failure because you're getting that shunting intrapulmonary, across the duct and the PFO. Yeah. So ventilation is key. There are two sort of different entities in pulmonary hypertension. Primary, which is really rare, and that really speaks to a primary disorder of the pulmonary vascular endothelium, where it just doesn't relax, or there is an inherent pathological issue with it. These infants won't have respiratory distress because they don't have any lung parenchymal disease as such, and the chest X-rays will look oligemic because they don't have perfusion. So you basically get quite black-looking lungs. And these infants can mimic cyanotic heart disease because the lungs don't look terrible on chest X-ray, they don't really have much respiratory distress, and they're really quite unresponsive to oxygen. The secondary PPHN, which is most of the cases we deal with, will be secondary, which will be because of postnatal vasoconstriction or lack of vasodilation in that pulmonary vascular bed. And the pathophysiology of that is quite a broad range, and it includes probably the most common one, is meconium aspiration, where you get injury to the lung parenchyma, and then a combination of just direct injury and inadequate ventilation and therefore vasoconstriction. Congenital pneumonia, particularly GBS, respiratory distress syndrome, so hyaline membrane disease, where the alveolar just don't open up and don't recruit, and so you have a type 2 respiratory failure. You just can't ventilate, and they become acidotic and then slide down into this PPHN vortex. Some congenital heart disease will also will also have a component of secondary PPHN, TAPVR, for example, which is total anomalous pulmonary venous return, which is where the pulmonary veins aren't attached where they should be to the left atrium, but instead are draining to the right atrium. And the key to that is you get a pure right to left shunt across the atrial septum. Also congenital diaphragmatic hernia. But these infants will typically have respiratory distress, and they'll have lung parenchymal pathology, which you can see on chest X-ray. And often you have difficulties not just with oxygenating, but with ventilating as well. So both type 1 and type 2 respiratory failure. What we're starting to do more and more of in the neonatal world, definitely in units and then also in retrieval, is using bedside ultrasound to help in the diagnosis. And it's very useful in a retrieval setting to exclude major congenital cyanotic heart disease. And I'm assuming many of you do ultrasound. Yes. Okay, I'm sure most of you do, or all of you. And the things that support a diagnosis of pulmonary hypertension, but obviously you can see this in other conditions as well. But there'll be a significant tricuspid regurg, which will enable you to quantify the pulmonary pressure and whether that's suprasystemic. You'll look at the ductal flow, the pattern and the flow, and then the shunt across the foramen ovale. The ductus, you generally get bidirectional shunt, and across the PFO, you generally get bidirection as well. If you get pure right to left, as I said, that's TAPVR until proven otherwise, and has important considerations in terms of disposition or where that infant goes. And then acceleration in the pulmonary artery, so there's short time to peak velocity, also indicative of pulmonary hypertension. So our treatment strategies primarily center around reducing that pulmonary vascular resistance and then supporting the systemic vascular resistance. We used to try and push the systemic vascular resistance really high, but actually that just puts strain on an already strained heart. And so the systemic vascular resistance, we're really just trying to aim for normal systemic blood pressure around the 50th centile, which can be loosely estimated to be a map that approximates the gestational age. So for a full-term baby, we're looking at maps of 40 to 45. So in terms of achieving vasodilation and preventing vasoconstriction, just a little reminder about endothelial cells and smooth muscles. The processes that enable relaxation, the pathways include nitric oxide, which then feeds into the cGMP and CAMP pathways, which result in vasodilation, and that's where sildenafil works. It's a phosphodiesterase 3 inhibitor, so it enables, it prevents the breakdown of cyclic GMP. Milrinone is a PDE3 inhibitor, which we don't tend to use in a retrieval environment because of its long half-life, but is useful for infants that have prolonged pulmonary hypertension and will certainly be used in ICU. So the number one vasodilator is oxygen, most potent pulmonary vasodilator, and we aim for PaO2s 60 to 100, and ideally this should be right radial because that gives you the best indicator of what the alveolar gaseous exchange is, right? Often babies have a UAC, so umbilical artery catheter, but that will sit in the descending aorta, which of course will have some shunted blood across to it. So that will be slightly mixed. It'll be mixed blood. So the PaO2 in the UAC will be lower than the right radial. And the right radial gives us an indicator of how well the brain is being perfused. And that's what we ideally use as the target. But pragmatically, we use whatever arterial access we have, of course. We aim for saturations ideally of 95 to 96, if you can get them that high, so that the baby doesn't, we aim for 95 to 96. Almost all of these babies need to be intubated and ventilated, and ideally cuff tubes, which I know you all use, but it's been a recent revolution, I guess, in neonatal care to start using cuff tubes. There have been concerns for many years that cuff tubes injure neonatal airways, but the new micro cuffs are very gentle, and so we're moving towards using cuff tubes, and in a retrieval environment we do. The neonatal units are still using uncuffed. And the ventilation strategy really is to ensure adequate lung recruitment without over-distending the lungs. So this, you really need to think about what the pathology is. So if you have a meconium aspiration, you've got basically you should have normal volume lungs, and so you can use a normal tidal volume of 5 mils per kilo, which is quite a bit less than in adults. But your PEEP will be determined by the pathology. If it's meconium aspiration, you might well need a higher PEEP, sort of around 8 centimeters. And importantly, really need to avoid over-distending because that will significantly impair the venous return and get you into a whole heap of other problems. We aim for PaCO2 in the normal range, so 35 to 45, aiming to keep the pH between 7.3 and 7.4, but definitely above 7.25. So that's what we're aiming for because the respiratory acidosis makes things worse. In the context of congenital diaphragmatic hernia, we do allow permissive hypercapnia because you have essentially, you don't have 2 full lung volumes. The diaphragmatic hernia will have resulted in hyperplasia of 1 lung, and so tidal volumes would be less. You'd be targeting less, sort of 3.5 mils per kilo in terms of tidal volumes. The other potent vasodilator is nitric oxide, which we use in a retrieval setting, and we would start with 20 parts per million and titrate down. And then importantly, we sedate and muscle relax these babies, putting on mini muffs as well to prevent any stimulation from excess noise, because they handle poorly. When you move them, they desaturate. And if you need to really, often really flatten them so that the movement doesn't affect their hemodynamics. And there is a room for considering sildenafil. To my knowledge, Steve, I don't think we've used it yet. We do now carry it in the packs. I'm not sure we've used it there because generally the babies respond quite well to nitric oxide. Sildenafil has been used mostly in a developing world setting where they don't have access to nitric oxide. But the really refractory PPHN cases once they're in intensive care might have sildenafil added on when they're already at maximal therapy. As I said, milrinone we don't use in a retrieval setting because it's got a very long half-life. So in terms of the systemic vascular resistance, we aim for blood pressures around the 50th centile. So we need adequately filled, and we'd start with 10 mils per kilo of volume in the initial period while you're working out whether the baby might need other fluid. And I think this is an important thing just to caution. So in neonates in particular, they can be very sensitive to volume challenges. And if you've got a baby that's got significant PPHN, their right side in particular, the right ventricle, will be in trouble because it's pumping against a very high pressure circuit. And once these babies develop right heart failure, then that's really bad, obviously. So be careful with significant volumes of saline or fluid boluses. Depending on the circumstances, these babies, if they are born through thick meconium aspiration, there's probably going to be an element of asphyxia, which will result in a coagulopathy. And so these babies often will bleed and then will often need packed red cells or FFP. So you need to leave space for those other blood products. Otherwise, you'll end up with a baby that is completely overloaded. So in terms of inotropes, as I said, we aim for the 50th centile. At NETs, our first line is adrenaline because it has equal alpha and beta receptor stimulation. And then we might add noradrenaline if the blood pressure, the systemic vascular resistance is very low, and if the blood pressure is very low, but only if we're sure that the cardiac function is normal, because we don't want to have that heart pumping against a noradrenaline vasoconstricted circuit. And then sometimes if that right heart is starting to show signs of failure, so you've got a big liver, we might even give Prostin, even though this isn't a duct-dependent condition. You might actually give Prostin to keep that duct wide open as a pop-off valve. But bearing in mind, you will have lower SATs because you will open up that duct and you'll get right to left shunting more across that duct. Generally, the duct doesn't close, but there have been instances where the duct has closed and you do need to give Prostin to reopen that duct. And of course, the normal things, keeping normal temperature, normal sugar, being mindful of the hemoglobin, measuring the urine output. The babies, if they're flattened with morphine and Vic, will need IDCs, and keeping magnesium and calcium in the normal range so that the inotropes can work to their optimal capacity. And then again, depending on the circumstance, you might give surfactant and, of course, antibiotics. Once we've done all of this, if the baby is still not responding, you would consider high frequency oscillatory ventilation, which we don't have on our current systems, but might be trialed once they get to the unit. But it's very good at clearing carbon dioxide, not always that good at improving oxygenation. And then the next step, of course, is ECMO if everything else has failed. ECMO will be discussed or considered when the SATs remain persistently below 80% and the PaO2 below 60, and once the oxygenation index is above 25. The current criteria are that the oxygenation index needs to be above 40 for 4 hours for the baby to be eligible, but that's all under revision. And of course, you need to ask the question in time to be able to get to the baby to an appropriate site and cannulate it to start ECMO. So are there any questions about that? No?
Any questions? I guess my question is, how do you choose, how do you decide on volume when you're running inotropes on these children? Are you using ultrasound or, because you're titrating an inotrope to a blood pressure and pulse, I guess, and perfusion, and then how do you know when to give fluid?
Yeah, so generally before we start inotropes, without the benefit of an ultrasound, because sometimes these infants will be in whoop whoop and there won't be a consultant with an ultrasound there, we would give a 10 ml per kilo bolus just to ensure that there is adequate fill, and start adrenaline. But obviously, clinically assessing pulses, making sure that you can actually palpate pulses, and then guide further inotropes clinically. So can you feel pulses? Are you squeezing too hard? What's the precordium like? Is it becoming more hyperdynamic? Are you is this heart trying to pump against a closed circuit, or are you actually getting good flow? So perfusion, pulses, all of that sort of clinical. So constant reevaluation. If you have the benefit of an ultrasound, then obviously looking at flows and looking at the SVC flow to ensure that that's adequate return, and then the right ventricular and left ventricular outflow as well.
Excellent. Any other questions? We obviously had some time at the end, but.
So to go on to a case, and this is loosely based on a case we had recently. So the call came in at 9:06 in the morning. Pediatrician was calling from a base hospital a long, long way away from here, with an hour-old baby girl who's a 38-week of full term, 3.3 kilo, who is hypoxic, has significant respiratory distress, has pulmonary hemorrhage, and they're worried about HIE. And I know you've all got your phones, so just to check that you're familiar with the NETS calculators, if you type into a browser calculator.nets.org.au, I did print out some if you're interested in sort of doses and decision trees. Just have a quick look. So if you look at that, so there's an option there to print out a medication chart for a neonate. You can put in 3.3 kilos. And there's also other decision-making tools there, including in the context of hypoxic ischemic encephalopathy, so therapeutic hypothermia. So the further history at that call was that this was actually a low-risk pregnancy. It's mum's third baby. The baby is now an hour old, and it was a water birth with thick meconium-stained liquor. Anybody up the back want to just comment on what the significance of water birth is? Thick mec-stained liquor.
Is there dolphin music playing? Yes. Who wants to comment?
Jackie or Army? Steve?
So essentially you're worried about freshwater aspiration and potentially a pneumonitis from that. Mm-hmm. And you can also get pulmonary hemorrhage as a consequence of aspirating water in this patient. So you treat it like a drowning, essentially, pediatric drowning. But the thick meconium stained liquor, if the baby's inhaled some meconium, it can also cause a pneumonitis as well.
And what happens to the surfactant?
So surfactant becomes denatured with meconium aspiration, and so you may need to replace that surfactant.
Yeah, so what we've got is a water birth and thick meconium, both of which can inactivate surfactant. And we've also got thick meconium. So this was a low-risk pregnancy and delivery because she's actually been allowed to have a water birth, but the baby's got thick meconium. So this baby is distressed for some reason prior to actually arriving into the world, and also now has the added problem of probable significant surfactant inactivation. So the pediatrician explains that the baby is hypoxic in 90%, and they're only managing to get SATs in the low 90s, and they've currently got the baby on CPAP with a PEEP of 8. The baby's also hypotensive, and they've just noticed that the baby's developing pulmonary hemorrhage, and they're worried about perinatal asphyxia. So the odds at the time of the call, the heart rate was 119, respiratory rate 30, Blood pressure was 49 on 27 with a MAP of 33. So really we'd be wanting MAPs of around 40 for this infant. The capillary refill time is prolonged at 4 seconds, and the preductal sats are 98. Not sure what the postductal is at the moment, but the baby's in 90% to achieve that. The baby's cold, 35, and the sugar is 2.4. Any comments about the sugar? Is that low? Is that high? Is that normal? First day of life?
No sugar.
Yep, so we like sugars to be above 3 from a pediatric point of view. On the first day of life, actually, a sugar above 2.1 is normal for a neonate. But if the sick neonate, you'd be targeting sugars above 3. So yes, the sugar's a bit low and will probably become even lower. Baby's a bit cold at 35 degrees, and we've already discussed the signs of hypoxic respiratory failure, and the baby is hypotensive with an impaired perfusion. So the issues then in summary are that this baby has hypoxic respiratory failure. They're planning to intubate. They'll give surfactant. The baby's got pulmonary hemorrhage. They've given vitamin K IM, but they're giving IV as well, and the coags are pending. The baby's hypotensive, and they're just giving the third 10 ml per kilo normal saline bolus. They've got 2 cannulas in situ and a low UVC, but they're not sure which inotropes to start, and they're asking for guidance. And they're worried about hypoxic ischemic encephalopathy because the APGARs were 0, 4, and 6. So 0 at 1 minute, 4 at 5 minutes, and 6 at 10 minutes. And by that stage, the baby was tubed, and so further APGARs can't really comment on. The cord arterial gas pH is 6.9 with a lactate of 14 and a base excess of -20. And they're asking, should we start cooling the baby? Any comments on that cord gas? Is that normal, abnormal? Okay, I've got down fingers at the back, so that's abnormal. So cord gases below 7 we really worry about. Lactate 14 and a base excess of -20, this baby's got a significant acidosis, which again speaks to that perinatal distress, which resulted in the meconium stained liquor, and asphyxia, and therefore concerns about ischemic encephalopathy. So it's a valid question. Should we cool this baby? The baby's already cold. Baby's 35 degrees. What does that do to the pulmonary hypertension and the hypoxic respiratory failure? It makes it worse. So if the baby's cold, it gets even worse. Okay. Baby was hypoglycemic initially at 0.7. They gave it 2 ml per kilo bolus of 10% glucose, and the sugar came up to 2.4. And they've given antibiotics for what it's worth for the distress. So this is a very sick baby. The current gas, so at 1 hour of age, the pH is 7, so hasn't improved terribly much in the hour. Base excess is still -14, and the lactate is 19, and the baby's in 90%. So this is the chest X-ray. Who would like to describe that? Okay. So there's no pneumothorax, which is good. Okay. We've got fairly well inflated lungs, 1, 2, 3, 4, 5, 6, 7, 8.5. So we want 8 to 9 posterior ribs in an infant. The cardiothoracic ratio is probably okay. Remember, we've always got quite a big thymus, which makes it look a bit bigger. But the lung parenchyma, do you think that looks normal? Normal? No, not normal. And what does it look like? Does it look heterogeneous? Does it look homogeneous? Yeah, it looks like an adult with ARDS. Yeah, it looks overloaded. Yep. Yep, okay. Yep, we don't have one in yet. They literally, yep, don't have an NG in. So I'd say that's homogeneous, and it's what we would describe as a ground glass opacification. So you might in an adult see this picture in ARDS or PCP pneumonia, but it's basically those little alveoli don't have surfactant, aren't able to open up. You're getting inflammation, and you've basically got this diffuse, inflammatory, non-recruited picture. Does it look like meconium aspiration syndrome? Well, it could. MEC-ASP generally, you get more heterogeneous, so you get a lot more patchy, but babies don't always read the textbook. But I would definitely say that this is consistent with RDS, surfactant inactivation, yes, with meconium aspiration as well, probably. But the bottom line is that there's lung parenchymal injury, so it's a secondary PPHN, hypoxic respiratory failure. So what advice would you give? So let's start with the PPHN. They're planning to intubate and ventilate. I think we'd all agree that that's a good idea. We suggest they use a cuff tube if possible. Do you know what size tube you'd use in a neonate? So go back to your phone. This is why this is so, well, we at NETS love it. So it'll actually give you guidance. So if you're not familiar with neonates and children of different sizes, it'll suggest the ideal ET size and also the distance at the lips. So if you look at that, cuffed ET tube using a 3.5 if you're going to use uncuffed, and if you tube orally, 9 centimeters. The Curasurf dose is on there, 200 milligram per kilo. And what are we going to do about this pulmonary hemorrhage? That's a bit worrying. What are the principles of managing pulmonary hemorrhage? I'm sure it's the same in adult land.
Yeah, just correct the coagulation problems.
Yes, and what else from a ventilation point of view or respiratory support point of view?
I'm not sure of any magic. We just need to
increase PEEP?
Look, if you need to oxygenate them, yes, but we don't want to increase PEEP severely on a hypotensive patient because that may cause other problems. But PEEP is one of the most important parts of oxygenation in the adult world, I'm sure, in all human world. But things like positioning, we do more for adults, I guess.
Mm-hmm. Okay. So we would go up to 8 or 9 centimeters of PEEP in the context of pulmonary hemorrhage, and of course correct the coagulopathy. We don't actually know what it is yet because we don't have the coags, but we'd give IV vitamin K and we'd start with FFP in the first instance. In terms of the HIE, should we cool this baby? So so if you go back to your phone and you look at that calculator, there's a neonatal therapeutic hypothermia decision tool. And I guess I just want to draw your attention to the exclusion criteria. So if the baby has significant PPHN with an FI2 above 80, you really need to think carefully about cooling because you know cooling them is going to make that worse. And if the baby has a severe coagulopathy, because again, cooling them makes a coagulopathy worse. The inclusion criteria, there needs to be a good story or history to suggest that there was an asphyxial event, gases to support it, and the baby needs to be encephalopathic. So at this stage, we probably shouldn't cool this baby. Everybody agree? Yeah, okay. So in terms of the hypotension, they've already given three lots of 10 ml per kilo, and they want to start some inotropes. We would start with some adrenaline at 0.05 plus or minus NORAD. Hypoglycemia has been managed. Any comments or questions at this stage?
No. I've always wanted to ask a neonatologist why normal saline?
Why not saline?
Why normal saline?
Oh, why normal saline?
We haven't given adults normal saline for like decades because we know it's not normal and it's completely unphysiological, and there's all these other good things like plasmolite and Hartmann's. But
yeah, and I think the answer to that is probably that there's no specific trials in neonates. And so we still just use normal saline. But having said that, we try not to give babies much volume in terms of normal saline because that's not usually the problem. Volume is not the problem with infants. So you'll give a little bit just to make sure your inotropes have got something to work with if you're flying a bit blind and you haven't got the benefit of an ultrasound to see if the heart is well filled. But actually you need room usually for blood or for clotting factors and blood products. So it's not really that APLS mindset of 20 mils per kilo, 20 mils per kilo in neonates at all. And we tend not to give much fluid at all. And if we do give, we start with 5 mils per kilo and another 5 mils per kilo. So really small volumes. Yep. Anybody want to add anything? Okay. So the baby was tubed. Lungs pretty much look much the same with that diffuse ground glass. And the team have arrived by the stage and have established right radial access. And the baby's been ventilated on pressure control, cyst control at 34 on 8 with an I time of 0.5 and a rate of 60. Any comments on those ventilator settings? No, it's fairly high pressures for a neonate, 34 on 8. Long I time of 0.5 and a rate of 60 means we don't have an ITE ratio of 1 to 2. But in this instance, it was working. And the pH had improved significantly, 7.27. And actually ventilation wasn't a problem. PCO2 was 32. Oxygenation, still a problem at 35, the lactate of 11. So the oxygenation index at this stage is 60. I'm just looking at the time. Probably need to move on a bit. In the interim, the hemoglobin had dropped with this pulmonary hemorrhage from 150 to 109. The coags were 2.2, which I think is after the first lot of FFP. And there was evidence of multi-organ failure with a creatinine of 90, ALT and AST were elevated. Electrolytes were otherwise okay. So nitric was commenced. The baby was resuscitated with FFP, cryo, packed red blood cells, adrenaline and NORAD at 0.1, and a hydrocortisone stat dose to support blood pressure as well. And the bedside ultrasound demonstrated severe PPHN with a dilated right ventricle, and the right ventricular septum was bowing into the left ventricle. And there was a bidirectional shunt across the ductus. Sugars were stable. Baby was well sedated on morphine and vecuronium. And the subsequent gas was improved with a PaO2 of 53, and the oxygenation index had come down to 40, but still significantly elevated. So up until this point, the management had been largely led by a neonatal intensive care unit, but given that despite maximal therapy, we couldn't get the oxygenation optimized, the baby's care was redirected to a pediatric intensive care unit with consideration for possible ECMO, and was managed on high frequency with fairly generous pressures, had multi-organ failure and MRI, had bilateral ischemic injury within the temporal lobes, but is now convalescing, establishing, NG fed, but convalescing, and on prophylactic anti-epileptic medication. So we've got probably just a couple of minutes for any discussion.
Any questions from the audience? Now's your time.
Thanks, Chris.
Of course, it's going to be Chris. Right at the back.
You can translate it for me, Carol. Just comment on the ventilation settings and the high pressures.
Thanks, Amber. Your comment about the high ventilation pressure settings on this child, is that something that you would see in mech aspiration, or is that a measure of reduced compliance in these neonates?
Yeah, so you'd get fairly stiff lungs with both RDS as well as meconium aspiration when you've got surfactant inactivation and difficulty recruiting those alveoli, probably in pneumonia as well. So they are quite generous. I mean, generally, to achieve tidal volumes in a fairly unwell neonate, you'd probably only need top pressures of around 20 to 25. So 34 is really quite significant. Yeah, but any attempts to wean this particular infant just really resulted in the baby desaturating and oxygenation becoming a real problem. So yes, it's a marker of how stiff and non-compliant those lungs were.
Thank you.
And just a practical reminder that on the Hamilton, you have to turn the Pmax up on the alarm settings to get higher pressures. So something to think about. Any other questions?